Okay. Am I visible?
স্ক্রিনশটটা চলে গেছে।
Okay. Now,
নট ইয়েট ম্যাম।
sorry. Is it okay now?
ওকে নাও শোয়িং।
Okay.
ওকে।
So we should start.
ওকে।
Hello everyone. Assalamu alaikum. I'm Dr. Afiat Hassan Shabnam. Welcome to our today's session. Today our topic is spine. It's our third class. So before start our class, do you have any questions? Let me know. As everyone is silent, so I think everything is okay. So let's begin our class today. Okay, if you have any question, feel free to ask anytime. Okay, before starting today's topic, I just want to answer the previous class question. There was a question that what is the ending of esophagus? So our esophagus end at T11 level. It is you can answer it at T11 level. Okay, it you can it starts from at C6 level and ends at T11 level. So that was the answer. Now I'm starting for today's session. Today our topic is back and spine. Though it is not frequently asked station, but in MRCS OSCE anatomy, there is no such thing that is more important, because any station can come to your come to as your station. So everything is important for the candidates who are preparing for MRCS OSCE anatomy. For today's session, our most importantly, we have to go through the cervical vertebra anatomy and it related question, lumbar vertebra, intervertebral disc, and some other scattered question and clinically relevant questions. Okay, so let's start. First of all, you have to know some basic knowledge about spine. In our spine, see, okay, see this area. It is cervical region and it is lumbar region. We have 5 regions in our spine: cervical, thoracic, lumbar, sacrum, and coccygeal. And here in a human being, in cervical region and in lumbar region, there is lordosis. Lordosis means inward curvature. See here, if you draw a midline line, there will be, this is inward. Okay, this is inward curvature and this is inward curvature. So in cervical region, you will get cervical lordosis, and in lumbar region, you will get lumbar lordosis in a normal human being. And in thoracic region and in sacrococcygeal region, you will get outward curvature. See here, outward curvature. It is called kyphotic or kyphosis. Okay, this is basic knowledge. Just for your knowledge, it should be known to you all. See here, in a human being, it is cervical region and it is lumbar region. This is inward curvature or lordotic, and in thoracic region and sacrococcygeal region, it is outward curvature or kyphotic. So for basic knowledge, in our vertebral column, 33 vertebrae in a fetus or child, but when we are getting adult, some bones are fused. So in total, then 26 vertebrae you will get in an adult due to fusion. So let's, it is not needed here. It is not asked about a typical vertebra actually, but if you don't know the typical vertebra feature, you won't compare with the atypical vertebra with typical vertebra. So for atypical vertebra, you have to know the typical vertebra. Atypical vertebra is a very important for MRCS exam, and it is commonly asked in exam. We will go through just for basic knowledge. In atypical vertebra, you will get a vertebral body. This is vertebral body, okay? This is vertebral body. You will get a vertebral arch, which is composed of pedicle. You all know this term, okay? Pedicle. This is pedicle, and this is lamina. And this pedicle in both sides and this lamina both sides, these all are composing vertebral arch. Then atypical vertebra has transverse process in both sides, a spinous process in middle or posteriorly, and a inferior articular process and superior articular process. It is all about typical vertebra. You have to know it to distinguish the atypical vertebra. Atypical vertebra is very important for MRCS exam in cervical region. And here, see, we have 26 vertebrae in adult, and we have 31 pairs spinal nerve. Come to this, why 8 cervical nerves, but only 7 cervical vertebrae? Here, see this image. Our C1 vertebra is passing above the, this one is vertebra, C1 vertebra, okay? And this is C1 spinal nerve. So C1 vertebra or atlas, it is called atlas. And C1 vertebra is passing above the C1 vertebra. And C2 cervical, C2 spinal nerve is passing below the C1 vertebra. So if you will see here, come to C1, 2, 3, 4, 5, 6, 7. Here 7, you will get above C7, you will get C7, and below C7, you will get spinal nerve C8. So here, tips or tricks, one tips and tricks, head is above. So in cervical region, the spinal nerve is above its corresponding vertebra. See here C1 vertebra and above C1 is spinal nerve, right? So C7 vertebra, you will get above C7 vertebra, corresponding, C7 spinal nerve, corresponding spinal nerve and corresponding vertebra. And below it, you will get C8, right? C8. And below C7, you will get C1 vertebra. That's the concept. Now come to typical cervical vertebra. It is C3, C4, C5, and C6. In a typical cervical vertebra, you will get a bifid spinous process. See here, you will get bifid spinous process. You will get a body, vertebral body, which is smaller than compared to thoracic and lumbar vertebra. Then you will get a triangular vertebral foramen. It is like triangular shape. And you will get a foramen in transverse process. This is all about typical cervical vertebra you have to know. And in case of atypical cervical vertebra, you will get 3 vertebra atypical: atlas or C1, axis or C2, and vertebral prominence C7. Okay. So in case of atypical vertebra, it is very important for our exam. Very, very important. It is frequently asked. So you will ask about the feature or identifying point. In case of atlas, there is no body. Atlas has no body. We have already shown that here a typical cervical vertebra has a body, but in case of atlas, no body and no spinous process. But in typical vertebra, you will get a spinous process, right? So it is why it is atypical, because it has no body, no spinous process. This is very important feature. Okay, you just can tell this feature. And another feature you can tell, if examiner will ask tell further, then you can tell. Large lateral mass articulate with occipital condyle and facet for dense on posterior surface of anterior arch. Okay, so it is ring shape vertebra. See here, it is ring shape, no body, no spinous process. Come to the axis. It's why it is atypical, because of its speciality of having dense. Another name is odontoid process. Dense, the presence of dense or odontoid process, it is atypical. This is axis and this is dense. Okay, this is dense and this is axis or C2 cervical vertebra. Now come to the another atypical vertebra. This is vertebra prominence or C7. C7, why it is atypical? Because it's long spinous process. See this vertebra. This is 7 cervical vertebra. Long spinous process. And it is the first felt spinous process. You can count the cervical vertebra from below to above. So this is spinous process. And it is the atypical feature of this C7. And small transverse foramen, because it doesn't transmit vertebral artery above C7 or from C6, from through transverse foramina you will get vertebral artery, but through C7 no vertebral artery, you will get only vertebral vein. So its transverse foramen is smaller than other. Okay, this is the important contents from spine, which is commonly asked or frequently asked in our exam. The important information here is to count roots start at C7 vertebra prominence, and you have to go above. Now come to the feature. Okay, this is very important. You will have to identify structure on cadaveric image. Before going to cadaveric image, I just want to tell here it is atlas. Atlas, see here, it is anterior tubercle. This is posterior tubercle. This is posterior arch. This is anterior arch. Okay, this is asked in exam in cadaveric image. So you have to keep concept on this. Anterior tubercle, posterior arch, anterior arch. This is superior articular surface of lateral mass of occipital condyle. Okay, this is lateral mass. And this is transverse foramina, and these two are transverse process. It's all about atlas, you have to know. And come to axis. Axis, this is dense. This structure is called dense. It is pedicle. This is body. And this is superior articular facet for atlas, inferior articular facet for C3. This is transverse process. Okay, now let's go to the cadaveric image. See here. What is A? It is the first cervical vertebra or atlas from above. Okay, so here see what is 7. We have just shown 7 is posterior tubercle. See here, it is posterior tubercle. 7 is posterior tubercle and 2 is facet for dense or axis. These two you can get posterior tubercle, and this is anterior tubercle and articular facet for dense. Okay, so we have to solve this. What is 7? What is 6? What is 5? 7 is posterior tubercle. This is posterior tubercle. So this is posterior arch. 6 is posterior arch. This 5 is lateral mass with superior articular facet. This is lateral mass with superior articular facet. 2, what is 2? 2 is facet for dens of axis. This is a facet. For what? This is facet for dens of cervical 2 vertebra. And what is this 3? It is very important. Okay? Most important. What is 3? 3 is groove for vertebral artery. This is a groove for vertebral artery. When actually we will go through the course of vertebral artery in our head neck session in detail, but here just you have to know by this, in posterior arch there is a groove and vertebral artery is passing through this. Now come to this B. It is from below. So what is 7? 7 is posterior tubercle, 6 is posterior arch, and 4 is here lateral mass with inferior articular facet. That was lateral mass with superior articular facet, that is round shape. That is kidney shape and that is round shape. Round shape is inferior articular facet. Lateral mass with inferior articular facet. And these 2, what is this 2? Facet for dens of axis, and 1 is anterior arch of tubercle, anterior arch and tubercle. Okay, these 2 is very important for our exam, and C is also important. C, what is C? C is second cervical vertebra from above. This 2 is here bifid spinous process. Okay, just see, 2 is bifid spinous process. 7 spinous process situated posteriorly. So 7 will be posterior arch, and it is here. This structure will be called lamina. Lamina. You will get 8. 8 is pedicle. Your articular surface, and 4 is here body. This is this is also important, but most important is this 2. It is also important, and others image just go through once. Okay. Now come to question. What is the first spinous process to be felt, or examiner can ask demonstrate it on the subject? So answer will be spinous process of C7, because it has a long spine, right? So sorry, it is also called vertebra prominence. When examiner will ask that demonstrate it on the subject, you have to just point out on the living subject standing there in exam hall. Okay, why we cannot feel the upper spinous process? This is also asked in exam previously. Answer is as they are short and bifid and attached to the nuchal ligament. What is nuchal ligament? Nuchal ligament, see this image. This, it is like this. So due to presence of nuchal ligament, this short spinous process containing vertebra cannot be felt. Just we can feel the longest spinous process of C7. These 2 are neutral question. Now come to another conceptual image. This is also recall question and frequently asked in exam. Before going to the questions, you have to carefully focus on this image. See here. This is our cleavus. What is cleavus? Do you know? Cleavus is a fusion of occipital bone and sphenoid bone. Okay, occipital and sphenoid. So here and in front of cleavus we will get foramina magna. See this image. I will just focus on those structure which will be needed in exam. See this image. It is cleavus, and this is C1 vertebra. This is C2 vertebra. It is a cut image, right? So C1, C2, and this is cleavage. So, see these ligaments, alar ligaments. This is cruciate. See here, this is cruciate shape. So this is cruciate ligament. And in exam, they can ask about what is this structure, what is this structure, what is this structure, or they can ask what is the component of cruciate ligament. So if you know the concept, you can answer. Cruciate ligament composed of superior longitudinal band, inferior longitudinal band, and transverse ligament of atlas. So these three components for cruciate ligament. And if they ask individually, what is this, what is this, what is this, just tell superior longitudinal band of cruciate ligament, transverse ligament of atlas of cruciate ligament, like this you can answer. So just focus on this. It is a recall question. And another image, these two images is also very important for concept. This is dense. We already have shown. This is dense. So from dense to anterior part of foramina magnum, this ligament is called apical ligament. From tip of dense to anterior foramina magnum. Okay, right. See, this is apical ligament of what? Dense. So, and these two are called alar ligament. This is alar ligament. This is alar ligament. See, this ligament. Sorry, this ligament, which is anterior to dense, is situated transversely. So it is called transverse ligament of atlas. See the name, transverse ligament of what? Atlas, because it attaches to atlas and to dense. Why we should know this information? Because in exam you will be asked that what is the attachment of apical ligament of the dense. So what is apical ligament? This apical ligament attachment is it extends from the tip of the odontoid process, to the anterior margin of the foramina magnum. Okay. Then next, what is the attachment of alar ligament? See, this is alar ligament, this is alar ligament, this is alar ligament. So if you can imagine this image, you can easily answer that it extends from the lateral side of the odontoid process. So this is odontoid process. So it extends from lateral sides of the odontoid process to the medial aspects of the occipital condyle. Here, this is occipital condyle, medial surface. So medial aspect of the occipital condyle, lateral margin of the foramina magnum, you can also tell. This is the attachment of alar ligament in both sides. Now, next question, what is the attachment of transverse ligament of the atlas? See this. Okay. So the attachment will be either in either side to a small tubercle of medial surface of the lateral mass of the atlas. The sentence is very extended, but just focus on this, that on lateral mass of atlas, its medial surface is this, and from a small tubercle, it start and crosses the odontoid process posteriorly, then it attaches another side. Okay, so the organized sentence will be, it is attached on either side of the small tubercle on the medial surface of the lateral mass of the atlas and crosses the odontoid process posteriorly. This is odontoid process and this is transverse ligament. Okay, these are recall questions. Now come to some important questions which are coming in exam frequently, that which ligaments are attached to the odontoid process. Very easy if you can keep concept on this image. it is odontoid process is not seen here. And behind the cruciate ligament, you will get odontoid process. So for which ligaments are odontoid process, you will get transverse atlantal ligament here. See this image, odontoid process, transverse atlantal ligament. You will get apical ligament of the dens here. You will get alar ligament here. So just focus on these two images, apical ligament, alar ligament, and transverse atlantal ligament. Okay, these three are the ligaments of odontoid process. Now come to another question related to ligaments. Which ligaments connects to C1 and C2? C1 and C2, for connecting C1 and C2, first you can tell transverse ligament of atlas, okay, or transverse atlantal ligament. And another two very easy name, just remember like this, that anterior and posterior atlantoaxial ligament. Okay, it is named after these two vertebra, atlantoaxial ligament, anterior and posterior, and a transverse atlantal ligament. So we have covered the questions related to ligament. Now come to the type of joints. Okay, what type of joint is the atlantoaxial joint? This atlantoaxial joint, which type? It is pivot type of synovial joint. These questions are very important because these are commonly asked in our exam. So don't avoid this. Atlantoaxial joint is pivot type of synovial joint. Atlanto-occipital joint, occipital and atlas. Between these two, the joint is ellipsoid or condyloid type of synovial joint. And what type of joint is present between the bodies of two vertebrae? It is secondary cartilaginous joint, or it is also called symphysis joint. Now come to this two movement question. What are the movements of atlantoaxial joint? That means C1 and C2. Between these two, it will occur the rotational movement. Demonstrate it on your own head, like no movement. When you will do the no movement, you will get the rotational movement, and it is between atlantoaxial joint, okay, between atlas or axis. And next, what are the movements of atlanto-occipital joint? It will be just demonstrate on your own head. It is S movement, flexion, extension, or combined it is called ES movement. And another movement will be occurred, that is lateral bending, you can occur. Okay, so this ES movement and this no movement, rotational movement, you have to be keep in your mind. Now come to the another most important topics which is coming frequently. Give me a few seconds. Okay, the radiological features of open mouth view of C1 and C2. Okay, if any fracture will happen, how will you identify it? It is very important question for MRCS. So see this is not fractured image, it is normal image. If you know the normal, you can identify the abnormal thing. Okay, so first of all, you have to know the structures. See here, what is this? Obviously, this is dense, we all know. And what is this structure? This two structure, it is lateral mass of atlas. So this is very important structure to know the alignment and to identify the abnormal and normal. So now come to what is one. One is arch of atlas. Okay, this is arch of atlas. Two is atlantoaxial joint. This is atlantoaxial joint. And four, what is four? It is body of axis. Three is three here. This is bifid spinous process. And 7 and 6. 6 is inferior articular process of atlas. Be careful about this bone's name here. It is part of atlas. And this 7 is part of, it is superior articular process of axis. Okay. So this is a standard radiographic view of the axis and its dens and intraoral view, or you can also tell it is a odontoid view or peg view. Okay. Mouth must be open to avoid dental shadow here. So you have to check the alignment that dens should be equidistant from lateral mass of atlas on both sides. So I have already told lateral mass and this dens, this distance should be equidistant, equal. Okay. See here, this is lateral mass and this is dens, and this distance should be equidistant in normal view. But when it will be abnormal, this distance will not be equal. So abnormal sign of fracture is unequal distance between dens and lateral mass. Dens and lateral mass, and you will get also prevertebral soft tissue swelling due to edema. Okay, due to edema, due to fracture. These are very important from spine topic. Come to this interesting image. It is not frequently asked or not frequently coming, but you should know. I have already told you have to count from C7, right? This is longest spinous process in cervical region. So from this longest spinous process, you have to count the read C7. So 14 here is spinous process of C7. You have to count above. C7, C6, 5, 4, 3, 2, 1. Okay. And here, just you have to know what is 2. 2 is here, as it is axis, its dens will be like this. So it is 2 is dense. And here come to 1. Here there is a correction. It is not axis, it is atlas. So here it is C2 and it is C1. And this will be anterior arch of atlas. Okay, this is the correction. Now come to this image. You have to know this is Scotty dog sign. You have to know, just see here. It is very important. Scotty dog is like this in real. So in our cervical vertebra, it is compared to Scotty dog. Okay. So in this oblique view, D, lumbar spine in oblique position, you will get a Scotty dog sign like this. Okay. So in Scotty dog, this is the nose of, this is Scotty dog. We will just see here. This nose is transverse process. Okay. This ear is superior articular process. This eye is pedicle, and this neck is pars interarticularis. It is also called isthmus. So isthmus and pars interarticularis, these are synonyms. And front leg, what is front leg resemble? It is like inferior articular process, and the rear leg, it is contralateral inferior articular process. And this body of this Scotty dog represents lamina, and tail of Scotty dog represents contralateral superior articular process. Okay, this ear is a superior articular process of one side, and this tail is superior articular process of contralateral side. This is Scotty dog sign. This is Scotty dog sign. Okay, and this is, it is oblique view. And C is antero-posterior projection. Antero-posterior projection. This view, in this view, you will got Scotty dog like this. This is nose or transverse process. This is ear of superior articular process. This is another tail of superior articular process. This is lamina. And these two are inferior articular process, and this neck is pars interarticularis or isthmus. And this is pedicle. See here, this is Scotty dog like this. Okay. This is very interesting. Now come to another important question, that vertebral level anatomy. So very, very important. In my exam, it is also, it came like C3. At C3 level, what you get? You get hyoid bone at C3 level. See here. This is the longest spinous process, or C7, right? So C6, C5, C4, and C3. At C3, you will get this. C3, you got this hyoid bone. This is the hyoid bone. C3, hyoid bone. And there will be X-ray image also. And there you have to identify the hyoid bone. I will show you. Next, at C4 level, what will you get? At C4 level, you will get C3, C4 between, or at C4 level, you will get upper margin of thyroid cartilage and bifurcation of common carotid artery. See here, this image. So this is C7, C6, C5, C4. So at C4 level, you will get this bifurcation of common carotid artery. Okay. And upper margin of thyroid cartilage. This C4 level, this is thyroid cartilage, upper margin of thyroid cartilage you will get at C4 level. Now come to the C7, I will tell C6 at last. C7, you will get first palpable spinous process, and we have already go through this. We have already covered this. So now come to C6. It is most important from here. C3 level and C6 level. So at C6 level, just I want to summarize it. See here, this is C6 level, right? At C6 level, you will get the entrance of vertebral artery through the vertebral foramen. So you will get this cricoid cartilage at C7. You will get the upper end of esophagus at C6 level. Focus on this image, upper level of esophagus. You will get the entry of inferior thyroid artery to the thyroid gland. You will get the superior end of trachea. Here, you will get trachea will be start from here. This image will clear your concept. Trachea, this trachea, okay? This upper end, it is starting from C6 level. So in summary, we can call that you will get at C6 level, that's cricoid cartilage or cricoid arch. You will get upper end of trachea at C6 level. You will get the entry of vertebral artery. You will get the entry of inferior thyroid artery to the thyroid gland. Okay. And maybe we have covered. Okay. Esophagus, the superior end of esophagus, you will also get at C6 level. So the mnemonic, you can remember that KVIT, cricoid artery, entering thyroid or inferior thyroid artery, vertebral artery, esophagus, superior end, inferior thyroid artery, and trachea. Okay, this is very important questions. And in head neck session, I will go through the vertebral artery code in detail. Thoracic spine is not important for our exams. Just for your knowledge, it is T8 spinous process is the longest spinous process in the thoracic region, and also clinically at T8 level, inferior vena cava passes through the diaphragm. We have already known that. Here you have to know about the zygopophyseal joint. Okay, what is the type of zygopophyseal joint? First, just keep concept. It is the joint between this is zygopophyseal joint between superior articular process of one vertebra with the inferior articular process of the vertebra directly above it. So this is the This is the zygopophyseal joint. And what is the type of this? This is the type of plain type of synovial joint. Okay, this is plain type of synovial joint. This is important from thoracic spine. Okay, so come to the lumbar spine. It is frequently asked question in our exam. This image can come for identification. This is the lumbar is vertebra, typical lumbar vertebra, superior view. And this is the vertebral body. This is the pedicle. This is the lamina. Remember about pedicle and lamina, pedicle is attached to the body, okay, and lamina is attached to the spinous process. LP, you can keep the mnemonics in your mind that LP, L is lamina near spinous process, lamina near spinous process and pedicle near body. If this is body, it can you imagine as a leg. Okay, pedicle. In Bengali, we called leg as pa. So pedicle and body. Now come to this transverse process, and here at base of this transverse process, you will get a tubercle-like projection. Process important. Note it. Then you will get at this superior articular process at this point you will get mammillary process. These two processes are exceptional criteria of lumbar vertebra. So this is mammillary process, this is accessory process. This image is very important. Now come to here. In the lumbar vertebra, typical vertebra, very large and kidney shaped vertebral body. Its vertebral body is large and kidney shaped comparatively to the other vertebra in body, and its foramen is triangular shape. It has no transverse foramina because transverse foramina was there for vertebral vessels, right? So no costal facet, no bifid spinous process. If spinous process is not bifid, right? Then mammillary process, articular process is present here. Just keep it, remember these three and these two. Now come to the cadaveric image. This A is very important. So we have already know the identification. What is this? This is spinous process. Compare with this, okay? It will be helpful. So this is spinous process. What is this? This is attached with spinous process. So lamina. This is lamina. So what is this? It is superior articular process, right? So superior articular process, and at tip of superior articular process, you will get mammillary process. What is 11? 11 is transverse process, and attached to body, which part? It is pedicle, and this is vertebral body. And see, just it is a view from the behind. Here we can see the accessory process at the base of transverse process 1. This is accessory process. Okay, and this is spinous process 8. This 9 is superior articular process, and 5 is lamina, 11 is transverse process, 6 is mammillary process. So here we can see that two process. One is accessory process and 6 is mammillary process. We can see here only mammillary process, okay? These two are important for exam. So we have already covered it. Now come to some scattered question that what is the level of lumbar puncture? We all know that it is at the supracrystalline L4, L5 level. I will show you picture later. What are the contents of the spinal canal below lumbar tree? The main content is chorda equina. Okay, chorda equina. It is bundle of lumbar, sacral, coccygeal nerve roots. What is the movements or what are the movements of lumbar vertebra? Very important. It is flexion, extension, lateral flexion, and axial rotation. Very limited due to sagittal facing facet. So flexion, extension, lateral flexion, and axial rotation. Sacrum is not needed. Now come to the another important topic from this spine session. It is intervertebral disc. From intervertebral disc, you have to just this picture. I like this picture. This picture is very clear for the concept. This is the intervertebral disc, and this portion is called nucleus pulposus, middle portion. Okay, it's pore portion, nucleus pulposus. It is gel-like pore and high water content. And around this, we will get the annulus fibrosus, the concentric layer of collagen fibers. See this another cute cadaveric image of intervertebral disc, that it is nucleus pulposus. This concentric portion is annulus fibrosus. Okay. So for our knowledge, it is also asked in exam that what is the annulus fibrosus? It is fibrocartilage and its own concentric layer. And sometimes they ask about the origin. It develops from mesenchyme. Just tell it. It develops from mesenchyme. And about nucleus pulposus, it is jelly-like material that acts as a shock absorber and origin from the primitive notochord. These two things are important. Sometimes it asked in exam. So we have already know that the facet or zygoprophyseal joint, it is secondary cartilaginous joint. And here, what type to the disc of aging? Okay, sorry, one thing. The zygoprophyseal joint, it is plain type of synovial joint. Okay, it is plain type of synovial joint. Keep this. I will here some mistakes maybe happen. Okay, come to this. What happens to the disc with aging? It is important. With aging, our intervertebral disc expands centrally. Okay, centrally. In nucleus pulposus, it expands centrally and becomes increasingly convex. Here, like convexity happens. Then change in hydrostatic pressure and lack of oxygen and glucose. Then due to dehydration and degeneration of that portion, annulus fibrosus might weak and nucleus pulposus can herniate. So this herniation can happen like this. It can be asked in your exam. So answer that disc expands centrally and becomes increasingly convex. And then there will be a change in hydrostatic pressure and lack of oxygen and glucose will happen. And dehydration and degeneration will occur, and weakness of annulus fibrosus happens, and nucleus pulposus can herniate for as a consequence. Now come to a tricky question. Actually, in case of disc herniation, in our exam, usually comes the posterior or posterolateral herniation of intervertebral discs. There is another type of herniation, it is lateral. We won't go to the lateral herniation, just focus on posterior or posterolateral herniation. It is, the consequence is same. So we know that in case of cervical region, the vertebra, the nerve and vertebrae. So spinal nerve and vertebra, the corresponding vertebra and nerve will be, organization will be like this. The corresponding um, vertebra, the corresponding nerve, and corresponding vertebra. But in case of lumbar region, the corresponding vertebra and corresponding nerve will be arranged like this. This is vertebra, between two vertebra, nerve will be present. And this nerve will be correspond to above vertebra. And in case of cervical region, this corresponding nerve will be is below vertebra. Okay, this is important. So when there will be posterior herniation, see this image, there will be posterior herniation between, suppose it is cervical region. So if it is C5 and C6, and there will be, it is the intervertebral disc and herniation, if herniation will occur, we will get the posterior herniation, we will get the compression of C7 nerve. This is C7 nerve. If it would lateral herniation, then it would compressed C6. But in our exam, usually comes posterior or posterolateral herniation. Focus on the question in exam. So if posterior or posterolateral herniation between C5 and C6, the compressed vertebra will be C7. And in case of lumbar 4 and lumbar 5, see this image, if posterior herniation, it is lateral herniation and posterior herniation will be like this. So if posterior herniation, see, it will be spared. But this nerve, like L5 nerve, will be compressed. So in very simply, just remember in posterior herniation or posterolateral herniation, the corresponding nerve of below vertebra will be compressed. Like if C5 and C6, between C5 and C6, this will be herniated posterior or laterally, then C6 nerve will be compressed. And in lumbar region, L4, L5, in case of these two, lumbar 5 will be compressed. So this is our exam question, that posterior herniation of lumbar 4 and 5 disc, which nerve root is affected? So answer will be lumbar 5. Okay. It is affected, and what will be the sensory deficit? Along the lateral border of the leg and along the hallux. See this image. You have to know the dermatome for this concept. So our L5 will be this region, right? So along the hallux or gate toe, and this and along the lateral border of the leg, this will be, and there will be sensory deficit. Okay. And if a similar question, if L5 and S1 between these two, what will be compressed? S1 nerve root. And see the dermatome of S1, sensory deficit will be this region. Okay. But most commonly asked this question. Now come to the another conceptual conceptual topic. It is ligaments of spine. Okay. First of all, see the image. Focus on the image. This is anterior longitudinal ligament. Okay, we have to know the three type. There are many ligaments, but for our exam, we should know anterior longitudinal ligament, and ligamentum flavum. So here, anterior longitudinal attachment will be asked. From the base of the skull. Before that, just I want to show this. It is the base of the skull, right? So our anterior longitudinal ligament, which this is our anterior longitudinal ligament. Always try to go through the image first for anatomy. Anatomy is a visual subject. If you just go through the writings or theoretical portion, you can't memorize the concept, or you can't crack the concept. So always go through the image. It will complete your like 2/3 of your study. So come to this anterior longitudinal ligament. It starts from the base of the skull. And here, this is posterior longitudinal ligament. It starts see here, it is dense, right? And this is C2, it is dense. And it is anterior. So, posterior longitudinal ligament starts from here and ends at sacrum. Anterior longitudinal ligament starts from base of skull and ends at sacrum. Okay. And our ligamentum flavum, this ligamentum flavum, we will, this is the ligamentum flavum, sorry. This yellowish color structure, this is ligamentum flavum inside the lamina. So this is also, you have to know, comes with the theory. Ligament origin from base of skull and to foramen magnum, and runs down to the front, 0 to vertebral bodies. This is vertebral body, and insert pelvic surface of sacrum. This is, see here, it is in here. Okay, this sacrum, this sacrum, this is sacrum. So posterior longitudinal ligament origin, its origin body of C2 runs inside the vertebral canal and behind vertebral bodies. Here we have already, I have shown you, and inserted posterior surface of sacrum. Okay, and ligamentum flavum. See this. See this image. This is ligamentum flavum, right? This is ligamentum flavum. So ligamentum flavum, notice the attachment. This lamina. This is a lamina. This is a lamina. Okay. And this is ligamentum flavum. Come to the theory. Lamina of one vertebra runs between adjacent lamina and lamina of the vertebra below. And just go through its action. Our anterior longitudinal ligament limits extension of spine. PLL limits flexion. And our ligamentum flavum, it helps recoil inflection. But most important, you have to know the insertion origin and just like you have to know. I think the concept is clear now. Just keep your mind this image. It will be very easy for you. Now come to the lumbar puncture. The most frequently asked question in both part A and part B. Okay, we have passed part A already, who are preparing for part B. So we already know these questions. So I won't go for the detail, and just see this image that is layers burst in lumbar puncture are skin, subcutaneous tissue. Subcutaneous tissue means it composed of subcutaneous fat and fascia both, right? Then you will get the interspinous ligament. You will get then the ligamentum flavum, sorry, before interspinous process, you will get supraspinous ligament here. Then you will get interspinous ligament, you will get ligamentum flavum, then you will get epidural space, and then at last you will get the dura mater. Here, what is epidural space? Very tiny space right here in image. See, this is epidural space, and this is ligamentum flavum, and this is dura. So dura mater, you will get dura mater, then you will get subarachnoid space, which is containing CSF, and then you will get chorda equina, spinal cord. Okay. So another question, level of lumbar puncture. See these two images. This is supracrystalline, right? This is supracrystalline in our body, and This is supracrystal line. So at the supracrystal line, what is supracrystal line? It is the line joining the iliac crest process L4 spinous process. Okay. So we all know that in adult, our spinal cords end at L1 and L2 level, and in child, it ends at L3 level, right? So below lumbar 2, it is safe for lumbar puncture. So we will just to be specific, the level of lumbar puncture is lumbar 4, lumbar 5, between lumbar 4 and 5. Our answer will be like that. Now come to the another conceptual image and topic, vertebral canal and intervertebral foramen. First of all, we have to know what is vertebral canal and what is intervertebral foramen. We have to identify. Then we can remember the contents. In exam, this content will be asked. But we have to know what is vertebral foramen. This is the vertebral foramen. Okay. So in successive vertebra, this is vertebral foramen, and adjacent vertebral foramen will form vertebral canal. And intervertebral foramen, which is intervertebral foramen? See this. Don't mix these two concepts. This is intervertebral foramen. It is formed by the superior and inferior vertebral notches of the pedicle. This pedicle, vertebral notches of this pedicle of adjacent vertebra, intervertebral foramen will form. So these two things are different. Always notice and don't rush to the answer so quickly. It can be wrong. Think few seconds, then you should answer. Now come to the contents. So in through vertebral foramen, our spinal cord, see, correlate with this, can correlate with this image. This is vertebral foramen, right? Imagine this is vertebral foramen. So through this spinal cord you will get, then you will get the spinal cord here at level of number 1 2, you will get chorda equina. Okay, then you will get meninges, dura, araconite, pia, and pyometer. And araconite space CSF will be present. You will get epidural fat, spinal blood vessels. This structure you will get. Anterior and posterior spinal arteries, intervertebral venous plexus. In a word, you can tell it spinal blood vessels. And if you want to tell it in specific way, then you can tell this. Now come to the structure passing through intervertebral foramen. See, this image is very good for that. Spinal nerve. Okay. Spinal nerve, dorsal root ganglion, segmental spinal vessels, arteries and vein, and recurrent meningeal nerve. Okay. So see this image. In vertebral foramen or vertebral canal, we will get the spinal cord, right? And from spinal cord, dorsal root and ventral root of spinal nerve we will get. So as in intervertebral foramen is situated here, we will get the spinal nerve root, both dorsal root and ventral root. And as dorsal root contain ganglion, we will get dorsal root ganglion also. And segmental spinal vessels, that means this spinal vessels. Okay, spinal vessels we will get, sorry, these are spinal vessels, and you will get the recurrent meningeal nerve. All things are not in the image, you have to keep memorize it. Now come to the I have already covered structure passing through intervertebral foramen. It is root of each spinal nerve. Very important. We have to tell it first. Root of each spinal nerve. Dorsal root, ventral root. See this dorsal, ventral. Dorsal root contain what? Ganglion. So these two you can tell it from here. Dorsal root, ventral root, and dorsal root ganglion. Then spinal artery of the segmental artery, communicating vein, internal, external venous plexus, recurrent meningeal nerve, and transforaminal ligament. Okay. there is a short mnemonic, nerves runs quickly crossing there. But I will suggest you just try to imagine the image and keep memorizing these things. Now come to another important topic, Berson's venous flexures. Okay. Don't go to the details. It is a vast concept actually, but vast and complex concept. But don't go to the detail. Just should know that internal vertebral venous flexures is called Berson's venous flexures. Okay. Berson's venous flexures is a network of valveless vein running the length of the spine. This and this information you should know that connects thoracic and deep pelvic vessels to the internal vertebral venous flexures. It is valveless. These venous flexures are valveless. Okay, and its blood flow is bidirectional. You have to know this, and very importantly, you have to know here is it provides a direct connection between abdominal and pelvic organ to the spine. I want to just show you a picture for this concept. Then you can understand it easily. See this section is like these are the in epidural space. These are the Berson's venous flexures. Okay, internal venous flexures. This longitudinal section. This is this section, and in this section. See, it is Berson's flexures. These are Berson's venous flexures. And see how it is like communicating the abdominal and pelvic via superior vena cava, azagus vein. It is connected like this. This is yellowish structure are Berson's flexures. See, it is connected to the superior vena cava. Okay. Actually, when it gives collateral circulation when there is occlusion in superior vena cava or there is a problem, it gives collateral support. Then in spinal metastasis, it also responsible. Clinical significance of Berson's flexures is it spreads or allows a spread of infection, tumor cell, increase intra-abdominal pressure, and transmission to the spine and cranial cavity. This is very important. That is what are the tumor containing organ, like which tumor are which tumor is responsible for spinal metastasis. So these tumors, the mnemonic is BBKPT. B is for breast and B is for bronchus, or you can remember it as lung cancer. Breast cancer, lung cancer, kidney cancer, thyroid cancer, and KPT, sorry, KPT, P is for prostate. So these are the structure when there is tumor of this organ, spinal metastasis can occur. This is a recall question. And how does spinal metastasis is occurring? By arterial spread, retrograde spread, and direct invasion via intervertebral foramen. There is no need to go for this as detail. Now come to paravertebral venous plexus components. Okay. So in paravertebral venous plexus or Berson venous plexus components, it can be count as external and internal component. Okay. So internal component, it has anterior and posterior component. Internal vertebral venous plexus. Remember this term, internal vertebral venous plexus and external vertebral venous plexus. And this external vertebral venous plexus and internal vertebral venous plexus both have anterior part. So you can remember like this, just add anterior and posterior in internal vertebral venous plexus, posterior internal vertebral venous plexus, and another two is anterior external vertebral venous plexus and posterior external vertebral venous plexus. Just go through this. Now another complex topic like spinal epidural space or extradural space. What is extradural space and what is spinal epidural space? Both are synonymous. First of all, you have to know that it is a space between dura mater and vertebral canal. Okay. See this. This is dura mater and this is ligamentum flavum. Between these two, this is dura mater, this is ligamentum flavum. Between these two, you can get the epidural space, right? This is the epidural space or extradural space. Now come to the contents. In exam, they ask about the contents of extradural space. These are epidural fat, internal vertebral venous. Come to the image first, then it will be easy. See, this is epidural space. Okay. So between which this is dura mater and this is ligamentum flavum. It is not marked here. So between dura mater and ligamentum flavum, or you can also call it vertebral canal. It is it is more safe that you should tell that between ligamentum flavum and dura mater you can get the epidural space. It is not asked usually, but you will be asked about the contents. Contents, see this Eolish structure, you will get epidural fat, right? This, you will get this space both side in transverse section, okay? This is the epidural space and this is the epidural space. So what are the contents? Contents here is epidural fat. You will get the Berson's plexus here, internal vertebral venous plexus. You will get spinal nerve roots. You will get small arteries. You will get lymphatics and loose connective tissue here. Okay, and meningovertebral ligaments. Just remember these names. See this image, it is more clear. So you will get fat, okay, epidural fat, you will get venous plexus, you will get arteries. Which arteries? Small arteries, like supply the spinal cord and surrounding tissue. You will get spinal nerve roots. Here you will also get loose connective tissue and lymphatics. Now come to the anatomy of the human spinal cord. It is not important from spine, just you have to know some information from here. Like we have already covered that it ends in children that at L3 vertebra, and in adult it is ends at the lower border of number 1. Okay, its length 45 centimeter. Just this information is enough from spinal cord. It is not asked in exam. We know that about the white matter, gray matter. It is not needed here. See this image. For the body image, this 17 is spinal cord. Okay. And here this structure is important. It is usually asked in head neck portion. Okay. So what is 14? 14 here is vertebral artery. Then you will be shown this image. They will tell that what is 14. You will tell vertebral artery. Then they will ask, tell me the course of vertebral artery. Then you have to tell the course. I will cover it in head neck portion. Okay. This is not important. These are not usually asked, but you will be asked about Waldenström syndrome very shortly. I am telling. Wait. Spinal nerve, no need. Blood supply of spinal cord. Just go through this. 1 anterior spinal artery and 2 posterior spinal artery. Okay, see this image. 1 is anterior spinal artery and 2 posterior spinal artery. You have to remember this. And another thing, they can ask sometimes that What is anterior spinal artery occlusion? One anterior spinal artery. So sometimes in aortic aneurysm repair or cross clamping can damage anterior spinal artery, and then anterior spinal artery syndrome can occur. As a consequence, paraplasia of bladder and bowel dysfunction will occur. So just keep it remember. So now come to the cauda equina syndrome in very short. You in exam you will be asked about what is cauda equina syndrome and what are the symptoms of it. So cauda equina syndrome, it is compression when there is compression on nerve roots below the end of the spinal cord. That means in cauda equina, then causing some symptoms. Which symptoms? Back pain, saddle anesthesia, lower limbs numbness and weakness, sexual dysfunction, and bladder and bowel disturbance. Here, interesting thing, what is saddle? Okay, saddle means actually it refers to the part of your body that would be in the contact with a horse saddle when you are sitting on it. The area like perineum, buttocks, inner thighs, and around the genitals, these areas are saddle areas. And in cauda equina syndrome, saddle anesthesia is an important symptoms. So back pain can occur, lower limb numbness, weakness, sexual dysfunction, and bowel and bladder disturbance. Question will be asked like this: that what is cauda equina syndrome? Okay. So we have covered the spine and back session for today. And we will cover some exam images when we will take mock exam. This is all about from spine and back. I have have tried complete the exam oriented topics mostly. Okay, I didn't go through in detail. It will take too much time, and I think there is no need from spine. These are the important topics from spine. And do you have any question from this session? Please let me know.
Afia.
Yes.
It's Dr. Nahida. It was
Yes.
such an excellent class, and I can recommend that it was one of the best spine anatomy class I have ever found in online. It's quite good, and the slide preparation is excellent. Pictures are quite good. Thank you so much for your reports, and I hope you will be teaching us more and more. And thank you so much.